conducting and few more webinars in the coming days. As you all know that tumor mutation profiling using the next generation sequencing has become a standard of care and a standard of diagnosis for many patients with advanced cancers, either upfront for the first-line treatment selection or later on in the disease evolution. Many academic centers have established their own NGS platforms, and in parallel, many commercial providers are also now available and giving clinical diagnostic services in the field of molecular diagnostics, including next generation sequencing. We know that the interpretation of the NGS data on the bioinformatics label is challenging, and clinicians generally get an extracted report summarizing the most important and potentially clinically relevant results, including a classification of the relevance of the observed genomic alterations. This session is going to help clinicians in understanding the terminology used in the reports. In addition, every oncologist should be able to check the significance of a reported alteration in commonly available databases. So I would like to wish this webinar, which is going to help the clinician in the regular practice. And before I hand it over to Professor Soumyaranjan Malik, I would like to Srikant to project that single PowerPoint slide on how to know which MPI has. Could you, is it audible? Is it?
Sir, I already projected the slide, sir.
Yes. As you all know that MPAI has been working in the field of oncology for the last couple of years. And after AstraZeneca had joined hand with us, we have been academically very vibrant, and we are trying to give through an online platform dedicated to oncology and particularly to breast cancers. We are giving comprehensive information through a site called her2know.in. And if you do this course, you are going to get, at the end of the course, you have a small test, and at the end of it, you'll get this certificate, what is being shown here. And in this, we give comprehensive information, detailed insights into HER2 testing methodologies, interpretation guidelines, and diagnostic updates. This educational resources will stay updated with the latest research, clinical trials, and e-learning videos. Dr. Savitri Krishnamurthy from MD Anderson Cancer Center has helped a lot in formulating this particular program. The community and collaborations are quite good. We are connecting with peers, sharing best practices, and contributing to discussions shaping the future of HER2-positive breast cancer management. The certification process is very important. Once you go through this her2know.in, we will certify you from the MPAI after reviewing and exploring handpicked clinical cases for her2know IHC scoring. So this is a wonderful tool to update yourself with the current breast cancer scoring methodologies. And I wish that you must popularize this particular site, her2know.in. And with this, I would like to hand over the further proceedings to Dr. Soumyaranjan Malik, and he will take it from there. Please carry on.
Thank you, Deepak sir. So, sir has already introduced regarding this session, why we are conducting this webinar. So, it is basically to create awareness regarding the NGS report interpretation. We have already organized this early of this month, like 5th July, regarding NGS decoding, and it is the same continuation process. So as you all are aware, multiple labs are providing NGS report, and many times the molecular pathologists use many molecular jargons. So it is regarding the awareness, how you get the best out of this report and to know about the quality of the report. So for this, we have experts from the medical oncologist or from the lab side. Today, we have to moderate this session, Dr. Ullas Batra. Can you please have the slide, please? Dr. Ullas Batra is a medical oncologist that deals with. May I request Dr. Srikanth for the slide? Okay. So Dr. Ullas Batra is the DM in medical oncology from the prestigious Kidwai Memorial Institute of Oncology. Currently, is working in Rajiv Gandhi Cancer Hospital as a co-director of medical oncology and chief of the thoracic medical oncology. He has gained a wide experience in managing solid malignancy, lung, breast, and GI cancers, also hematological malignancy. He is already preceptor from various international institutes like MD Anderson, Royal Albert Hospital from the Australia. He has already co-investigator and PI, also co-PI in many phase 2 and phase 3 clinical trials, numerous publications to his credit. He also supervising thesis guide for the DNB resident, organized many CME, so many things credit to Dr. Ullas Batra. So he will be moderating today's session regarding this decoding NGS report. And for the panelists, we have two from the lab side, Dr. Firoz Ahmed, head of clinical genomics Unipath laboratory. From the one more oncologist, Dr. Bindya, from senior consultant medical oncologist from Omega Hospital, Hyderabad. Then Dr. Minu Angi, consultant cytogenetics from Unipath Specialty Laboratory again. Then Dr. Surchi is always with us for the last two sessions and is the head of the scientific affair MedGenome Lab. So I'd like to hand now thank you all for joining this webinar. So thank you, Dr. Ullas. So it's to you to start this panel discussion.
Thank you, Dr. Malik, for the very kind words. And it is so nice to see approximately around 143 people already have joined the panel. Trust me, I didn't know that these many people will come and join. Otherwise, I would have prepared some more better slides. But that is it. But the good part of being a moderator is I don't really have to do much. And I only have to ask questions. And ever since this COVID came and NGS came, they both didn't come together. NGS came first and then the COVID came. We have had many molecular sessions. And the break which we got in the COVID when the patients were less, I actually utilized that for knowing what exactly happens behind the scenes. Because to me, that is very, very important. Especially in our context, when there are so many labs which are there are so many institutes and everybody says, I'm the best, I'm the best. There's a small anecdote that I like to quote. There was a breast cancer, ovarian cancer patient, and we had ordered for an NGS panel. And in the end, the report came something and we treated. Later on, we found out that she also was a BRCA mutant. So very angry, I called up my molecular pathologist and I said, Madam, what is this? Why didn't we do BRCA before? So she said, she said it was not a part of panel. I said, what the hell do you mean it was not a part of the panel? She said, if you don't know what you asked for, how are we going to get? As a clinician, I did not understand at that time that there are different things. When I tell, and I actually tell my postgraduate residents that, before you do whatever, there are two numbers that you should be very aware of, the molecular pathologist, because I think molecular pathology NGS report is like a Donald Trump. Whether you like him or hate him, you can't ignore him. So, ultimately in 10 years, 5 years time down the line, NGS is going to become like a PET CT scan. It will have its advantages, fallacies and everything. But majority of our patients will get NGS done. The molecular thing is going to revolutionize the medical oncology. And any medical oncologist or any oncologist who does not know NGS, the intricacies, the nuances of that is actually going to lag behind. So I must credit the AMPI Association to have webinars like this. And I really hope that this comes into a very learning curve. It has been a learning curve for me, thanks to all my colleagues at Rajiv Gandhi, who have actually taught me the NGS report. And let's see if we can do some justice to this. So these are my esteemed panelists today. Dr. Vindhya Vasini, she's the only oncologist on the board. I don't envy
Hi,
her
sir.
job at all. I don't envy her job at all today. And but Vindhya, welcome. We also have Dr. Feroz and Dr. Meenu Angi from Unipath, and we have Dr. Suruchi, who is working very hard and still at the Med Genome Lab. You can see the banner behind you, and let's hope we can have a good discussion. So, this is how a sample NGS report actually looks like to us. This is actually a NGS oncomyid myeloid V2GX something. But trust me, this is what I tell my patients actually, that you have two Janam Kundlis. One Janam Kundli was what your parents made for you at that time. And one Janam Kundli or your second birthday or Janam Kundli is what we actually get for you right now. So this is what will exactly tell you what is going to happen to you and how are you going to behave. But that is what I do before the test orders. The moment I get the report, this is exactly what I look, whether the result is positive or negative. And I don't actually look at, all these things, the clinical details or, variants, DNA sequence, RNA sequence. But to me, after having gone through all these things, I think that one thing which I have circled over here is just the tip of the iceberg. And any success stories require a lot of the backside work, the bench to bedside, the work which happens behind the scenes. And to me, that behind the scenes is what the molecular pathologists do. And their role is and the scientists do, and their role is far more important than the credit that we actually give them. And the brickbats that we actually, lay at them. So this is what we actually see. So I'll ask Dr. Vindhya first. Dr. Vindhya, is this right? Is this the only thing that you see in the report, or there's something else also you see in the report?
Yeah, basically first I look at the actionable or targetable, whether there are any actionable mutations. So that is the only thing that worries me, because when we do these costly tests and we don't find any actionable mutations, the patient is devastated.
Correct. So that is one thing that we do. That is one thing that we see, but there are a lot of things that we should see also. And, let's just find out what exactly things we are going to do. The second question which comes to my mind always is that, why does it take so much of time? And after so much of time, after 10, 15, 20 days, when the patient comes and tells, ki, sir, wo report, and then the molecular pathology will say, QC failed. So my first question to Dr. Feroz, so what exactly happens from the time we give the sample to you? How much time, and does it happen that if it is let's say your hospital's chairman's known to, what is the earliest that you can get the report to me? And why does it take so much of time? What are the steps for the benefit of all the panelists and everybody with the audience that have come, in clear, simple language, no medical jargon? Otherwise, I'll also start using atezolizumab and big things over there, ADCs. In clear language, what exactly happens? Dr. Feroz.
Thank you, sir. Thank you for setting up the tone of this wonderful session. As you rightly mentioned, sir, many times even we get questioned, ki, why are you taking so much of time for reporting an NGS report? And there are clear reasons for it. There could be a pre-analytical and analytical issue. So once the sample is received in the lab, the first and foremost thing what we do, if it is a solid tumor paraffin block, it goes to our histopathologist to check whether the block which has been sent to us has optimal tumor content or not. This is the
Dr.
first
Feroz,
and important thing.
Dr. Feroz, can I just stop you here? I'm going to
Yes,
stop
sir.
you in between, and I'm going to say, let us start
Yeah.
from January 1. So let us say a sample comes to you on January 1. When do you give the report?
So technically, sir, on an average, on January 12 or January 15, between 12 and 15.
So I am going to ask you the report. I am going to ask like a nosy housewife or a nosy
Please.
spouse. I'm going to
Please,
ask
sir.
you details of what happens in those 15 days.
Done.
So January 1, you have got the biopsy thing with you. You
Yeah.
send it to your histopathologist to see whether the tumor content is good or not.
Correct.
So my one request to all the pathologists, and I'm sure everybody is listening over here, I'm not going to be a nice person. Why can't we report this prior only in the block or in the thing that is there? The tumor is, and that is what happens at our hospital. Every pathologist who reports this thing writes over here, tumor tissue adequate for molecular testing. the cellularity is more than 30%. That is a standard thing which is written in our reports.
Yeah.
If we do this step, will it save some time?
Absolutely. At least it would save, I say, 24 to 48 hours.
तो 2 दिन हमने आपके पिछले 5 घंटे बचा लिए.
Absolutely.
Okay,
Agree.
Dr. Sarochi has a point. Yes, Dr. Sarochi.
Yes, sir. Sir, actually, you know,
First of all, my name is Ullas, and we will stick on to that. Please go ahead, Dr. Sarochi. For
sure,
benefit of
sir.
people
My
who
name
don't
is
know me.
also Suruchi then.
Yes,
No,
Dr.
Dr.
Sarochi. Tell me.
Yeah,
I never
no
called you
problem,
madam
sir.
or something.
So,
Tell me.
okay, the point that I want to make here is that when we receive the block, okay, the tumor content which is written in the histopathology report is the first exam that has done on that tumor block after it is prepared. But it would have undergone or may not have undergone certain IHC tests
Okay.
or certain other tests. Okay, so when we take the sections from those blocks and when it comes to the lab for next generation sequencing, that sectioning process also depletes the tumor cells.
Okay.
So that is the reason that, you know, each and every block that is received at lab for NGS has to undergo histopathology examination, H&E examination for tumor content evaluation. So that's the first point, because if
If
tumor...
if you have an in-house lab, or if the person who is giving, see, we are all colleagues, we are all friends, we are all working in this journey to help the patient. Can it
Right.
happen that we can make a guideline or something so that anybody who issues a lab writes over there and then sees the thing, because it will save time?
Definitely, it will save time
I
if
think
it is
that's
done. But as a CAP accredited NGS lab, it is like a first QC step that has to be done, because if tumor cellularity will not be there, there is a chance that the NGS report can be false negative.
Okay, fantastic.
So it's
once
not
there
about
is-
the quality. So there are 2 points, doctor, here, because I do get these kind of questions and I actually want to clarify this. Pre-analytical, there are 2 points. One is the amount of the tissue and one is the content and the quality of the tissue. So tumor content and the quality of the issue, these 3 aspects.
Can
So
you see the
first
quality of the issue in your H&E slide?
No, we
No,
cannot.
you can't.
Quality will be known only after we do
Correct.
the analytical steps.
All that you need is a tumor content, whether it is more than 30% or not. Is 30% good enough or 10% is good enough?
10% is validated as good enough. Ideal is 20% or more.
Okay, fair enough.
And quantity of the tissue. Quantity of the tissue means sometimes we do receive core biopsy samples. So where multiple sectioning already has been done. So the amount of the tissue, I would say, amount of the tissue on the block is sometimes low. So that also determines, you know, whether we will get enough DNA out of it or not. So that is the first and foremost check. And then if the tissue amount is enough, we take the section, do H&E and determine the tumor content.
Okay, so if you have an in-house lab, we will save 2 days. Because your histopathologist is the one who is sending. Fair enough. Let's go ahead with Dr. Feroz. So Dr. Feroz, once you get this on January 1, you have sent it.
Yeah.
In January 2, your report, which basically comes over there. Then what happens?
So then, sir, if as per the guidelines, if the tumor content is good enough, then it will go for the extraction, whether it is a DNA or panel or DNA RNA both. So basically, extraction process will take.
I have a question. In
Yeah.
today's era, what are the tumors in which we are doing only DNA panel? Or as a lab, we will do both DNA and RNA, because for a clinician, it is very, very important. Vindhya, I'm sure you will agree with me, because all our fusions and all, you know, at least in lung, the ALK, the ROS, the fusions are basically identified better on an RNA.
Yes.
So is there a condition, and are all the labs doing a DNA RNA, or there are certain labs which are doing only DNA?
So now there are multiple choice which are available to you. Like say, let's say a colon cancer patient.
Correct.
There you don't need to do any kind of RNA fusion because you don't have a much targeted treatment when it comes to RNA fusion.
Do require RET, and because see, now they are tumor agnostic from a clinician's point of view.
Sure,
When I
sir.
send for NGS, see, if it's a single gene KRAS or BRAF, I can send in a single gene assay only. The entire point of sending a NGS panel is I want to actually look at some fusions also.
True.
So, you know, there are cases of NTRK in, you know, this, which is a fusion, which is not really a mutation. There are cases of RET in that. HER2/neu also can come. So, I like to take somebody that, I mean, correct me if I'm wrong, and there's more of a learning also. Should we be doing, I mean, and how much does it take extra to do both RNA and DNA? I mean, how much, what extra efforts comes? I mean, sorry, it's a layman question, but how much? I'm just trying to learn.
So if I have to answer you, sir, when it comes to RNA is always a labile and sensitive molecule and very unstable molecule. So the chances of getting compromised quality of RNA, which will ultimately affect your NGS result, is very high. Even though you have the best fixation time, or even for that matter, best quality has been done during the fixation and all. Still, when it comes to FFP tissue, RNA is always a challenge sample to extract. So if there is a choice, DNA is always preferable. But again, because of the targeted treatment, now it is slowly, the cost-wise, it is almost now negligible. DNA and RNA almost is same now, because the panels which are being offered is hardly, it comes in the range of 15 to 20,000 on average, everything.
I'm asking, is it DNA or DNA and RNA? I'm not debating the fact that only this thing should be done, or is it I mean, how much the difference in the cost and everything between DNA or DNA RNA? I'll come to you, Dr. Suruchi. Let Dr. Feroz.
So but RNA, because RNA, for example, fusions can already minimally you need to do on RNA only, because when you do it on DNA, the chances of missing out is very high. So RNA is the best molecule to identify all fusions. In such scenario, you need to do RNA fusion there. There's no doubt on that.
Dr. Suruchi, you have a point.
Yeah, so sir, as you mentioned, in your introductory note, that we need to first of all define the objective of our testing, and that is the most important point. Like in different indications, we have to understand what is the objective of our testing, and then we can decide whether what panel we have to use. Because in India, India is a patient pay market, so we have to have different options. We have comprehensive options also, and we have targeted options also. Now, coming to your second point, that whether DNA should be done or DNA plus RNA should be done, or like fusion detection on DNA or RNA. So there are labs which do fusion detection on DNA also. But as Dr. Feroz also mentioned, it is much more reliable when we do it on RNA for two reasons. One is that fusions these are the translocations which happen at DNA level only. So at chromosomal level only, the translocations or rearrangements will happen, and DNA has exons and introns both. So the breakpoints can be intronic or non-coding regions also. However, most of the panels, whether DNA or RNA, they are designed based on exonic regions or coding regions. So there is a high chance, if the breakpoints are rare or the probes for those breakpoints are not included in the DNA panel, the fusion is bound to get missed.
That's so bad.
And this is the same concept that we use when we design the panel for liquid biopsy, because liquid biopsy, there is no RNA. We are doing all the tests on ctDNA. So we have to be very careful and mindful when we are designing a fusion panel or ctDNA, that we have to include those intronic breakpoints where those common fusions occur. So that's why it is very difficult to identify rare fusions through liquid biopsy. So this is one concept. And on our...
Yes. Yes, Dr. Suruchi.
Yeah, so RNA, when we do fusion detection, sir, we are using exonic probes. Now, imagine if we look at the central dogma, the fusion has happened at DNA level, some translocation has happened, and that translocated DNA is now getting converted to RNA. So now what will happen is introns will be spliced out. So the mRNA that is formed is only the exons of gene A and the exons of gene B. So gene A is fused to gene B, and this is the transcript that we are looking when we are doing RNA sequencing. So we have exonic probes of gene A, for example, in the panel, but we do not have exonic probes of gene B. But the exonic probes of gene A will amplify half of the sequence of gene B. So that's how we can identify known as well as unknown partners, even if they are not in the panel for RNA sequencing. So that is how we identify the rare partners of oncogenic genes through RNA sequencing, and it is much more reliable. Another concept is RNA is expressed...
One second. Too much for me to absorb right now. Let me just go to the clinician right now. Dr. Vindhya, when you look at the report, do you ask your service provider, the people who, if you have an in-house or outhouse, whether a DNA or RNA, especially in lung and other malignancies, whether it has been done?
Yes, that is very... I do ask. I do confirm whether RNA is included, because nowadays, most of us prefer DNA plus RNA NGS.
Okay. And also, is it written in the file, in this thing, or you have to ask? Or somebody they
It
write
is
something
usually
over.
written, it is
Correct.
usually written.
And also there will be a good practice to write, that is what we have said, that maybe RNA was tried, which we could not extract, and therefore
Yeah.
RNA, the quality was not very good and we could not do, just in case. But
Yes.
by and large, we want to do RNA and DNA from a clinician's point of view, because when we send for a panel, unless or until we obviously ask for that, we would want a DNA RNA panel also. To look for at least common mutation, at least the tumor agnostic things which are approved, we would want to look for that. Okay, Dr. Suruchi, I'm just cutting you short. Dr. Feroz. So
Yes, sir.
we have sent to the histopathologist. We have broken down the DNA, fragmented. Then we are going to amplify.
Right.
Okay. Then what happens?
Then so roughly this will take around day 4 as per you. Like let's also go by the day, number of days.
Okay.
So
Yes.
DNA extraction and then quality check. Again, FFP tissue, lot of quality issues. So you need to check whether the DNA is suboptimal or optimal for amplification or not. If not, then you have to re-extract the DNA. So that also adds to the time. So same thing goes for the RNA also. You extract the RNA, you do the quality check, and again look for the quality. If the quality and quantity is good enough, then you go to the next step. So roughly it takes,
At what time do you know whether the quality is not good?
so I will say day 4, day 3 to day 4 will come to know the DNA quality and quantity.
Okay. Is
And
it
on the days,
so,
yeah.
Dr. Vindhya, how much time have you got a call from the lab to you or to the patient saying the quality is not good, send a repeat biopsy? Or does it happen only after 2 weeks?
Maybe it's 7 days, 7 working days, 7 to 10
We-
working days.
So it will always be a nice idea to, maybe, I mean, I'm talking as a clinician, because once the patient comes to us after 15 days, sometimes it does happen.
Yeah, sometimes it does happen that the patient reminds or comes asking for the report, and then they say that it has not passed QC, we need another sample.
Yeah. So sometimes it is
It has
always,
happened.
it's a good idea for the labs to, I mean, whether it's an in-house or outsourced lab, to tell us after 4 to 15 days QC passed or something, so that we
Yeah.
are aware that we don't need to get a biopsy done, because for patient, they want the treatment started yesterday. So even if we would have smoked the entire life, they still want an EGFR to come positive, and they'll say, "Arey, wo QC fail ho gaya, isliye report nahi aayi." Okay, go ahead. So now we have fragmented, we have amplified the DNA. Then what
Yeah.
happens? QC check done.
So then if everything goes well, so technically on day 5, the library preparation will start. So library is nothing but whatever you have extracted, whether the DNA or RNA, you fragment the DNA. If it is an amplicon based, you use certain primers to target the hotspot, say for example, EGFR, exon 19. You will amplify only those regions and you will remove the other regions. And if it is a captured base like Illumina, you will use the probe base. So what you will do, you will fragment the DNA, you will ligate the DNA with certain adapters and molecular barcodes. So these adapters are universal sequences, which helps the DNA to get sequenced when you do the NGS analysis. So a pool of DNA fragments with adapter and molecular barcodes are practically called as libraries. So these are the molecules which goes into the sequencer for further sequencing. And so technically, let's say day 5, you have put your library, day 6, your library is prepared. So you do, again, there is a quality check wherein you check the library quality, concentration, and if it is good enough, then you will take it for sequencing. Now here another catch is that, sir, you don't sequence single sample on NGS. So that is the biggest challenge for any NGS based lab, is that you have to pool samples. You can't run a single sample on a single chip, which is very expensive. So at least a batch of 5 to 10 samples if it is a smaller panel, or 4 to 6 samples if it is a bigger panel. So depending upon the panel, you will pool samples. And once you pool the sample, you will put it on the sequencer, whether it is an Illumina platform or Thermo platform. So Thermo usually takes around say entire library preparation, chip preparation, and sequencing 24 to 48 hours. So you add another, so day 8 you will have your sequencing data run done.
Okay.
On day 8. Okay. And then what happens, the raw data which comes out from the system is in the form of a digital, like the NGS machine detects the sequence in the form of a digital, like binary number 010101, because these are millions and millions of sequences which is being done. So the BCL file, which is what you have mentioned in your slide, is the first rawest file which comes from the system. This is in the form of a 0101. So what we will do in order to make it readable for humans, like whether it is A, T, G, C, we'll convert that BCL file into a FASTQ file. So
Okay.
this is another set of file which is called as FASTQ file. And once you have FASTQ file, what you will do, you will align those sequences with the human genome or a reference genome so that you understand whether the sequence which you have generated on the sequence is aligning completely with the reference sequence, or is there any kind of variation. Let's say you have aligned your sequence with EGFR exon 18, 19, 20, and you found that in exon 19, my sequence, which has come from the NGS, is showing some deletion. That's how you'll come to know. And that file which is generated is called as variant file or VCF file. So basically, these are variant file which gives you information how much your sequence is changing from your reference genome. And once you have variant file, you will do a tertiary analysis wherein you will try to understand what is the significance of these variants, whether it is relevant, whether it is clinically relevant, whether it is reported, whether it is a very novel variant. So this is something what we call as annotation. So you annotate the variant and then you do the analysis.
So can I ask, I mean, fantastic. So I basically what I found, what I realized is BCL files are the raw data, then you convert into the FASTQ files, and then you do the VCF file so that you can find out. Now, what I want to ask is, how much of this, to Dr. Minu, she has not really commented now, is how much of this is, let's say I look at a FASTQ file or a BCL file, how much of this is observer dependent? So if I analyze a report and you analyze a report, Dr. Suruchi analyzes a report, Dr. Feroz analyzes a report, Dr. Vindhya, how much is the chances of a inter-observer variability? Dr. Minu?
Yes, sir. Sir, actually, this is compared with the human genome. So
Correct.
chance variability is little because base to base it is compared, and according to that, the variants are called.
Okay. Fantastic. Dr. Suruchi, if you have a different answer to this?
Yeah, I would like to add. So basically, the variant called file is, as Dr. Feroz mentioned, are the variants that we have observed in the test sample as compared to reference genome. Now we have to annotate it. So annotation happens basically based on, available literature evidences and variant minor allele frequencies in population databases and so on. There are different parameters to annotate these variants. So after these variants are annotated, the genome analyst will actually interpret it. So there it can be a little variability based on how you are looking at the variants. The variants which are well defined in the literature, usually variability is not there. However, the variants which are like of uncertain significance or we don't know the significance, so those difficult variants for which the literature evidences are not there or we don't have much information, so that variability can be there, that some labs may report a VUS or some labs may, based on the analysis or based on the interpretation of that particular variant. This is one variability. The other variability is based on the quality.
Once again, what you are saying is I and Vindhya can't report. We need you guys only to report. That's exactly what you are telling. Yes, please go ahead.
Standard guidelines have to be followed for reporting, and there are multiple parameters which annotated variant file will give us, definitely, yes. So genome analysts are required to do the molecular reporting. Another point is on the quality of the variant. So again, this annotated variant file, VCF file will be, we have to quality pass the variant. So when we validate a particular NGS panel, like a target set or a target probe set I have designed, and we have to validate. So validation means we have to decide how much data has to be generated, what will be the limit of detection, what will be the QC parameters of bioinformatics pipelines, all those things when we do Illumina sequencing platforms. So all those things are set. So if all the variants are passing those quality control parameters, then they are good to report. But sometimes we do get actionable variant which are below our reporting criteria. Now, and especially for FFP.
Yeah, you look at say EGFR at 3%. What will you do?
Exactly. So especially in FFP tumor blocks or CD74 ROS1 fusion at just 2 reads.
Yes.
So it is an actionable variant. Data quality is not so good, but it is actionable variant. So for the benefit of the patient, sometimes we do report it with a note that, okay, with disclaimer, we have to, confirm it by IHC, or we have to
Okay.
take a call
I-
accordingly.
Can
Yeah.
I just ask you to, I'll ask Vindhya. Vindhya, do we always look at the reads and the depth and everything, or we just saw ROS fusion present and we'll give crizotinib, or should we be looking more into that actually?
I think we should look into, but is that what is the difference with the WAF that we see?
VAF
Where-
I'll come to. I will
We'll
come
come
to VAF that over
But
there.
read depth, I think if we go deeper, even if it is a low frequency, then also we don't know the significance of it, but we
I
still
will
need to-
come to that. I will come to that when they are in some time. The only first slide only has taken so much of time. So, Dr. Suruchi, although this is there, now what I basically wanted to ask, and the first question, and there's a question in the chat box also. So let's say if there is some mutation, let's say somebody has come as negative, and let's say I've sent to A lab, the report has come negative. Should we use a different panel? So how do we select the panels? I mean, what is exactly a hotspot panel? What is exactly CGP or something very famously called as CGP, whole genome, whole exome, targeted sequencing? I mean, some people may say, I'll do this lung panel testing for 10,000 rupees. The same one somewhere else goes, he says, no, I will take it for 70,000, we'll have more genes. So for the naive medical oncologists like us, please explain.
Yeah, thank you, sir. This is basically, we have to again understand our objective of testing.
Correct.
So there are two concepts for cancer. One is risk prediction, which we do through germline testing, and one is targeted treatment information or prognostication of the disease that we do through tumor testing or liquid biopsy testing. So now, whether to go for a genome, exome, or a targeted gene panel, if you ask me, for treating the cancer patient and for prognostication of the disease, targeted panels for tumors are much more sought after. They give us good quality on FFP. If you do larger panels like genome and exome on FFP DNA, the data quality is not poor. And even if we increase the GB of sequencing, the data generation also, we do not get average depth as recommended to be, calling the variants, calling the confident calls. So targeted gene panels are sought after, and also they should be indication dependent, because in India, our objective is cost effectiveness also for the patient. So targeted panels with, actionability should be sought after. Comprehensive genomic profiling has to be done, that is required, but majorly in advanced diseases, when we have exhausted much, almost all the treatment options, and we want to look at the genomic profile, complete genomic profile of the tumor, so as to get an idea like now what can be done for this particular patient, or to get the options like immunotherapy, like TMB, MSI. So in those cases, we have to do multi-biomarker panels. So this is what, like my personal opinion is that targeted gene panels should be done for cancer.
So
For
I
cancer.
have a comment and then I have a question. As a comment, I have a point. When you know what you are looking for, then you order a target hotspot panel. When you do not know when you're looking for, or for a research, then you do a broad-based panel that is either a exome or a genome. Exome and genome are expensive. Exome and genome will take time. You are not really sure whether what you are going to get from there. That is one. Small panels, you should look for when you know whether you're looking for only EGFR or ALK or only KRAS or BRAF and all. So if you have a 12 gene panel, please look for only 12. Your answer that you will get is only 12 gene. You will not get STK keep in that. You will not get P53 in that if that is not in the panel. So a lot of time people ask me, यार हमारे पास में P53 नहीं आता. I said, Baba, आएगा तो तब जब when you will test for it. If you don't test for it in the small panel, then how will you get it? So when you know what you're looking for, ask for a small panel. When you don't know what you're looking for or a research, ask for a broad-based panel. That is what my simple clinical judgment is. Now, the second question which I'd like to ask you, Dr. Feroz, will be, let's say I want to look for EGFR and I have done a hotspot panel. My report comes as negative. Now, will I do same sample, a broad base, maybe a genome or exome? Is there a chance that the same biopsy specimen will pick up that EGFR mutation. So
Uh,
difference between a hotspot and a EGFR in the same sample, the same patient, same time.
So the chances of getting a positive is very less, sir, because most of the hotspots which are clinically relevant are covered even in the smaller panels. So they are equally good, unless until there is some goof up in the sample processing or something like that.
नहीं, हम वो
Otherwise,
वाली बात नहीं करेंगे अभी वो गुफा की बात बाद में करेंगे.
so I don't think that this will be any additional information you will get it.
Okay. So does it also happen that, okay, so it also depends upon, like, you know, in exon 18, 19, 20, 21, what is the, you know, have you taken a part of 17 or not? If there is at the side of that, does it make a difference on that? Or so Dr. Suruchi, if you can answer that one for me?
Yeah, yes, sir. So if it is only hotspot variation, then you may not miss, but there can be chances that it is not a hotspot mutation, but some other
Correct.
mutation which is also oncogenic.
Correct.
And yeah, so if that is not covered in the hotspot panel, then definitely the
So what I'm saying is
panel
an
will be
L858R, after L858R mutation missed on hotspot and getting on chances of whole genome exome is very less, unless or until there is a problem in the panel, you know, when you have not taken that thing and all. Is that right? Is it a right statement to make?
Yes, sir. Because
Okay.
targeted panels, they do work well because we are targeting a specific region and the quality of the data that we get is good when we are
Correct.
targeting smaller regions. So
Correct.
if we are looking only for L858R, whether we do hotspot, even
It
hotspot, I would
doesn't.
say would give you better
Correct.
quality data.
Okay. Dr. Vindhya, your comments?
Yeah, I just wanted to ask, if we are doing only a hotspot, what are the minimum number of genes that we need to test to look for MSI and TMB?
Okay. In a hotspot panel, can you get a TMB and MSI? Dr. Minu, she is not answering. She is very silent today. Maybe two people from the same lab, only one will speak. Yes, Dr. Minu.
Sir, it depends upon how many genes are covered in that panel. Like in
Hotspot.
yes,
12 gene panel. Very, very
12
famous.
gene panel.
Made by,
So we need to, so we need to check the number of genes covered. So different labs have different hotspot panels. They have designed like that. Like we have 12 gene panel for lung. So if it is covered in that, then only it will pick up.
no, but Dr. Minu, that means you mean to say in that hotspot panel, 12 gene panel, I can hope that you will give me a TMB or MSI? Is that what
No.
you're saying? I don't think so.
No.
Now, so Dr. Feroz, if I want TMB or MSI, what is the basic size of the panel that is supposed to be there? Is that what Dr. Vinda is asking?
Yeah, I think, sir, for a TMB, 409 gene is what is the minimum number, because TMB is nothing but you are trying to locate how many gene mutation you have per MB of the DNA. So if you need to target at least roughly, now there are different approaches. Some people are using panel based TMB. Even some labs are giving out an exome also. But again, there are certain literatures which says that the panels versus exome, they give equivalent report. But again, the cost will be coming into the factor. So overall, if you say for TMB, at least 350 to 400 is gene is minimum required for getting a correct answer.
Dr. Vindhya, if there is one report that I'm very skeptical of and then giving immunotherapy, that is TMB. The cutoff, yes,
Yeah,
sure.
yeah.
So for TMB to be determined, the panel size has to be more than 1 MB.
1
Mhm.
MB, yeah.
Whether it is like 400 genes or 300 genes, or I mean, the
The
probe design that is made has to be more than 1 MB, then you can determine. And that also, you know, sometimes if you don't have a good quality FFP DNA, the data, you cannot have 1 MB complete coverage. So while
True.
determining the TMB, even if you are running a 400 gene panel, the quality of the data has to be looked upon very carefully, that whether we are covering the whole 1 MB, the coverage is good or not, because FFP will have that challenge. So TMB will not be determined accurately. If the coverage is low and mutations are high, then TMB will be erroneously high.
Correct. Absolutely right. And TMB, I think, practical pearls from me would be TMB is something, take it with not with a pinch of salt, take it with loads of salt. So this is, while I was speaking gibberish, this is a paper I would request everyone to read. This I read yesterday. And there is another article in JTO about bioinformatics. And that is also, I would request everyone to read, every medical oncologist, every resident, fellow, young consultants, And definitely old consultants should read this paper if they really want to have a sense of NGS actually. Please go through this. So, Dr. Vendya, I mean, the problem over here is we will require NGS for almost everyone. What is your confidence level in decoding the NGS reports across all the tumors? Tomorrow, if somebody tells you gallbladder may EGFR mutation, how confident are you in acting across it? I mean, so sometimes we do send NGS just for the heck of sending NGS. People will come and say, Doctor, that fellow, Dr. Ullas said, send one NGS. He sends for everyone. But that is predominantly because I see lung. And tomorrow you see gallbladder, you're not sending NGS. I will go to Dr. Ullas. That is why you send an NGS report, or why do you send NGS?
So basically, mostly in the advanced metastatic setting, NGS I usually send only in lung upfront, or hotspot panels in colon, or cholangiocarcinomas in some patients.
So breast cancer, I'll ask you, breast cancer, do you send an NGS?
Triple negative, maybe?
Yeah, I mean, and something comes out of that?
No.
Stomach cancer, do you send?
I do only HER2 and MSI PD-L1.
Again, so as a medical oncologist, I always tell my patients and my residents and my co-consultants, there has to be a pre-test probability of acting onto that. And if something comes positive on that, don't just send the test for the heck of testing. NGS is very, very good, but it has its own limitations. We are just in the learning phase. Tomorrow, I think we have to optimize our testings, the resources and everything, and then only send. Typically, in sarcomas, I do a lot of sarcomas, and sarcomas, they come. I am yet to get anything meaningful in sarcomas. Sometimes, rarely, we'll get some NTRK or something, very rarely, 1% of tumor, but very, very rare to get. But let's say you have a report. Do you, Dr. Vendya, are you confident one is whether you would send the test, and how confident are you about the validity of that report or something else of that report? I mean, will you act on that report always? All the tumors?
It depends on if it is an unusual mutation or a unusual subtype of the mutation, then maybe I might not act on it.
Okay.
Provided I still have the standard options available. If all the standard options are exhausted, then I might try out this NGS recommended treatment options.
Correct. So that brings me, Dr. Vindhya, to the database. So do you only, so I was telling my daughter yesterday, trust but verify. We trust everyone, and that's my standard thing in my unit also. We trust but we verify. Now, do you trust all the reports that have come, or do you also verify? Let's say you get some unusual one. Do you use the databases like ClinVar or OncoKB or something? And if yes, which one? If no, why not?
I have not used. I have
You
not.
have not used over there. Fantastic. So I will ask Dr. Suruchi only. Should the medical oncologist take everything on this thing, or we should also use our databases and look at Oncovar or whatever, ClinVar or OncoKB something?
Sir, actually, in cancer, I mean, in multiple indications, we have actionable variants which are quite well defined. So if they are tier 1 variants classified according to AMP guidelines, then I think it is
There is
okay.
no issue.
Yeah. But if there are tier 2 or tier 3 variants, and we do not have any tier 1 variant that we have got on that report, and we don't know how to, use those next generation sequencing results that we have got, some tier 2 off-label variants or like tier 3 variants. In those cases, yes, we can look at certain literature and databases to understand the pathways, or to understand like how those variants would behave. So when we look at next generation sequencing report, we have two things specifically to look at: the gene and the indication, and the specific variant in that gene. So looking at gene and the indication doesn't suffice. We have to look at what is the variant in that particular gene. So the specific variant is very important. So sometimes I get a question that it is a BRCA is positive, or BRCA variant is there. But we have to look at what kind of variant is there in BRCA. Is it pathogenic, or it is variant of uncertain significance? So then it makes sense that, okay, there is the whole three things are completed: tumor indication, gene, and the specific variant.
And the specific is very, very important. And that is what the more and more you look at the NGS reports and more you discuss with the molecular pathologist or the scientist, that's very, very important. We should look at it and just not jump, the moment you have a gene which comes positive. It's almost like saying, EGFR mutations 19 is different from L858R, which is different from uncommon mutation of 861 and S761, which is very different from exon 20 insertion, which is very, very different from ERBB2 20 insertion. So as medical oncologist or as any oncologist, as the end user of that, we should also hold our horses and not have a knee-jerk reaction saying, congratulations, you have got something positive, and then just act on that. So, Dr. Feroz, abhi tak whatever you told me was, histopathologist, fragmentation, amplification, library, then BCL, FASTQ file. Now, where does the bioinformatician comes into this? And does every lab have a bioinformatician? And can we do away with them? Or should we do away with them?
So the role of bioinformatician comes immediately once the sequencing data is out from the instrument. So as you are already showing that there are three kinds of analysis which is being done once your data is out: primary, secondary, and tertiary. So we have already discussed that primary is nothing but the data which is coming from the machine gets translated into a readable format like ATGC, the FASTQ files. So this is the primary which a bioinformatician only can do. Even a genome analyst cannot do that because they are expertise in that in that modality. Okay. Then the second part is the secondary analysis. Again, here also the role of bioinformatician is very important and critical, because they will do the analysis, they will align the sequence which you have identified, and then they will make sense of and create the VCF file. And once this is done, then the tertiary analysis may the genome analyst. There's a new concept of genome analyst now. Last 3 to 4 years earlier, bioinformatics only used to do that, but now there are certain well-trained people who does the variant annotation and analysis, whether what is the frequency of that variant, whether that variant has been reported as a likely path or path, what is the clinical relevance, what kind of ACMG classification it is. So that kind of specialized role a genome analyst do. So yes, it's a mandatory requirement that whichever lab is doing an NGS, they should have their in-house bioinformatics team. And now there are various online pipelines which are available now. I mean, you don't need to sometimes like Thermo has a GenXS platform, which gives you end-to-end solution. You don't need to be very well trained. You run your sample and you get your data out, and then you interpret. So slowly people are trying to develop their own pipelines, which is always good. And of course, the role of bioinformatician is very important while doing the pipeline validation, because the calls which are taking is whether it is a true call, whether it is a false call, whether the data quality is good or bad. All those things are done by bioinformatician. So it is important, very important.
Okay. Dr. Vindhya, are we even aware of all these people who exist? The tip of the iceberg, we are not even.
I was just about to ask, what are the qualifications of a bio?
What are the qualifications? We can have one for the hospital. Okay.
There are MScs, PhDs in bioinformatics.
Yeah, and pretty brainy people, very, very brainy people. You talk to them, it's almost like, okay, fine. Why did I even talk to them? ये तो मुझे आता ही नहीं था. Okay, Dr. Suruchi, anything to add in this?
No, I do agree that bioinformatics plays a very, very important role, especially when we do validations. So we have to have I can tell you that there are almost 40 to 50 parameters, much more than that at their level probably, but what we look at and their pipelines that we develop basically has those quality checks. So if that pipeline, if that quality check is not passed, the data will not go to genome analyst for interpretation.
Can I interrupt you? If I use a machine, if I use a GenXS machine, then the bioinformatician's role is only to validate the data, and then his role or her role will be redundant. Is that what we are saying?
The GenXS machine, actually, they have a I would say like pre-designed panels and the pipelines, which is, there. And as Dr. Feroz mentioned, that the data will be analyzed in that box, and it will be, available for the analysis for to genome analyst like that. But when we use Illumina sequencing platforms, we have to have certain designed bioinformatics pipelines with quality check parameters, which are defined at the time of validation, at the time of those panel validations. And it is easier for germline variants But when it comes to FFP or liquid biopsy, then definitely it has to have a lot of customizations and optimizations and undergo lots of quality checks. And that's how we have a control of data. We have integrative genomic viewer, which can be used to visualize the reads. And that is a mandatory practice, like any variant that we are reporting has to be visualized, that how is the read quality basically. One is the base quality, which is done by the pipeline, and then is the read quality, like how the reads are, bioinformatics reads are.
So now I will, I think I never expected us to go for so much. It's becoming very interesting now. It's becoming so much of learning actually. So both this question I'm asking on the mine and Dr. Vindhya's behalf. Vindhya, I mean, if I can use your name, because to me, when I initially thought about VAF, the higher the VAF, I think the stronger this is there. And so let's say you have a BRCA2, a VAF of 75.9, A, it is germline, B, it is very, very strongly driven by BRCA. How wrong is my thinking in this? Dr. Suruchi. So for general, if there are medical oncologists also listening, what exactly is VAF? Is it a predictor of germline? Is it a predictor of driverness? Is it a predictor of how strong my medicine is going to react to this?
Sure, sir, definitely. And my pleasure to answer this question. So basically, VAF is a variant allele frequency, the full form, and it is a very important parameter when we do next generation sequencing, because next generation sequencing, how it is different from Sanger sequencing is that we sequence a particular position multiple times. Okay, when we sequence a particular position multiple times, those multiple sequences that we get, we call them as reads. So a particular position that is being targeted is sequenced multiple times. So variant allele frequency is the number of reads with the variant, means with the change at that position, divided by the total number of reads that have been generated for that particular position. So for example, I did a next generation sequencing for L858R. And the total number of reads generated for that 858th position in that DNA sequence is 100 reads, and L is changed to R 25 times in those 100 reads, then the variant allele frequency is 25%.
So the common fallacy with the medical oncologist think is 25 of 25 EGF, it's EGFR bar EGFR plus ALK plus ROS plus whatever. So that is not really the case. That's what initially I thought. It's the amount of the abnormal reads bar the total number of reads that gene has been read.
And it will vary from sample to sample. It is a very sample specific parameter. It is not like minor allele frequency, which is a population database frequency. It is a that position, particular position in this report. If you see C dot position here, nucleotide change. So at this position, 83X is the total depth, and 75.9% of 83 reads contain this particular mutation or the change. So that is VAF. Now, why VAF is so important? VAF is important because it gives us a lot of information. Theoretically, if we are doing a test on tumor tissue, it is related theoretically to the percentage of the tumor cells, tumor cellularity in that tissue. So if tumor cellularity is high and the VAF is also high, then it indicates it could be a driver mutation. However, if tumor cellularity was high, but still we are getting certain variants at low burden, it could indicate a subclonal population for that particular variant or minimal residual disease if we are doing it after the treatment. That is one aspect what VAF gives us. On the tumor tissue, if the variant allele frequency is high and it is a genetically predisposed gene for cancer, then it also indicates that it could be a germline variant. So where germline confirmation becomes important, it is not distinguishing that whether the variant is somatic or not. For example, in this report also, 75.9% is quite high, but the test is done on tumor tissue. So we don't know as of now that whether it is a germline variant or it is a somatic variant, but indication is there that it could be germline. So we have to confirm it on the blood of the patient that whether it is germline or not, and that can be done by Sanger sequencing. On the germline report, when the test itself is done on germline or blood DNA, we do not give VAF. We give homozygous or heterozygous, which is again based on VAF only. At the back end, based on variant allele frequency only, we will determine whether it is a heterozygous variant or it is a homozygous variant, whether a single copy. Yeah.
Dr. Suchi, yeah, because time is short. Tell me, if you have a VAF of 4.8% EGFR in a
Mhm.
tumor cellularity of 30%
Hmm.
implication, what will you write it as? Driver
So
mutation, L8858R,
the
4.2%.
VAP we mentioned along with the depth.
Yes.
Yeah.
Yes, we do mention along with the total depth.
Yes, Dr. Suruchi. So answer my question.
Yeah. So, sir, if it is a 4.8% EGFR L858R, definitely it is an actionable variant. The limit of detection is usually 3 to 5% for any next generation sequencing assay if the tumor content is 10% or above. So tumor content is 30% and I'm getting EGFR at 5%. The EGFR L858R will be reported.
Yeah, and I will want to treat that, but I will like to tell my patient, I will like to, when I see a VAF of 4.55%, I would like to reassess my patient slightly earlier than what is usually expected. This is what I would do as a clinician on that. Fantastic learning. That was very, very nice. Next one is Dr. Feroz. What is this reads and depths that they keep on talking about? You know, tell me and Dr. Vindhya in fast, because we only 20 minutes remaining.
So, sir, technically, the read depths are the same. The number of sequences you are reading at that particular locus. Say, for example, in this case, total reads were 100. So, out
Okay.
of 100, how many? The same. This is the same. It's,
Correct.
read depth.
So now tell me how, when I look at a report, what is the minimum reads and what are the minimum reads that should be there to for me to say it's a good report, both in liquid biopsy and a tissue biopsy for somatic and germline variant? Just an answer for that.
So, sir, for germline, as I said, in terms of reads, 2 million reads per sample, like which will be equivalent to report a VAF of 30 to 50% is good enough. And when it comes to somatic, anything which is more than 1500x, 500 to 1500x is a good year to go ahead.
Dr. Saruchi?
So for germline, we usually sequence at 80 to 100x average. Yeah, for somatic, we do target the data so that it gives average depth of 250 to 500x. So that we can
500x is okay?
Yeah,
I mean,
if the tumor
real, like,
content is, yeah, as per the validation criteria, if the tumor content is above 10%, so we can confidently call at 250x to 500x.
Okay. So now we have this patient who's a 38-year-old female, metastatic CA breast, and I would not have sent actually ERBR positive, HER2 neu negative. Test performed was a comprehensive tumor panel plus TMB plus plus MSI. In a normal word, I would not have sent this report, but then it is there. So Dr. Feroz, this is the report. When you have a BRCA, you know, there's some heterozygous deletion, and they're also asking for MLPA. A lot of time when you ask for BRCA, you ask for NGS or you also do MLP. And what exactly is this? So I'll ask Vindhya first. Vindhya, when you ask for BRCA, do you also ask for MLPA or just the BRCA? Or we just write BRCA1 and BRCA2 and then let the report come?
If there is strong family history, then and if the BRCA is negative, then I try to go and ask for an MLPA later on.
Okay, Dr. Feroz?
Yeah, I agree with Pam. Like for example, any NGS for picking up, basically MLP is nothing but it's multiplex ligation based probed assay. And it is a good technique to detect large deletions and duplications, which cannot be picked up by even the best of the best pipelines in the NGS. So whenever an NGS report is negative, then in that case, and as madam suggested, if there is a very strong family, like for example HPOC syndrome, then in that case the probability of getting a deletion duplication is very high for BRCA, and in such scenario it should be consulted, the MLPA test. But again, the concordance, like many labs, even we have done some validation wherein if you are detecting a CNV or a large deletion duplication on NGS, the concordance is 70%. Still, there is a probability that 30% you will miss out. So in such scenario, the gold standard which we say is that MLPA, it should be verified by MLPA.
Okay. Okay, here it is for Dr. Sorichi. Okay, this is HRD. So, you know, I mean, I always again tell my fellows, abhi NGS समझ में नहीं आया था कि HRD आ गया है. So, in the meantime, I'll answer the question over here. But what is exactly is HRD test? And Vindhya, first of all, again to you first. how frequently do you order HRD in ovarian cancer, and do you always order? And how confident is your report, and do you treat on the basis of HRD report? Or do you always say that HRD, myriad scoring was 42 and other labs have different one? How do you what is the confidence level of Indian labs reporting HRD? And then I'll go to Dr. Suruchi.
So in all ovarian cancer patients, I do advise for HRD now that we have a free coupon from AstraZeneca. And the HRD tests that are done in India are slightly different from the myriad score. And the foundation one test, I think it uses only LOH, and the other Indian tests, they use different methodologies to arrive at the score. Though I'm not particularly clear about what methodologies they use, but still this is the only options that we have. Not all patients can afford the myriad scoring.
Correct.
So with
So-
the available HRD testing in India, I think I usually follow, or if it is positive, I usually consider it as positive and give them the option of PARP inhibitors.
Correct. So Dr. Suruchi,
Yes,
HRD
sir.
is all yours. Tell me.
Thank you so much. Yeah, thank you so much. So right now, I mean, till now we were discussing about the variants, or we were discussing about single nucleotide variations or insertions, deletions, or fusions, right? So HRD is a kind of a phenotype. It's like a, cause and the consequence kind of a relationship. So cause can be certain mutations which are happening at HRR pathway genes, or it could be certain other changes in that pathway which is making it defective. And this is the phenotype that we observe. Phenotype means what is happening after that pathway has become defective. So the genome, when homologous recombination repair pathway becomes defective, can accumulate certain errors, and there can be certain genomic signatures across the genome. So like ma'am said, that myriad my choice uses a cutoff of 42, and we are using a cutoff of 40 as of now. Earlier we were also using a cutoff of 0, and we were using the cutoff of 50 also. So it depends on the technology that is being used, or the assay as such that is being used to determine the HRD, and the optimizations that happens around those technologies to determine HRD. So HRD is a signature, genomic signature, which happens across the genome when the HRR pathway becomes defective. And if we at MedGenome, like AstraZeneca coupon is available. So AstraZeneca and MedGenome in collaboration has developed HRD test, which is better in terms of quality and optimization as compared to the Chinese tests that we were using earlier, because there were no other options. And it has been validated with myriad my choice also with 100% accuracy. So this report basically shows the BRCA1, BRCA2 mutation status, and also the genome aberration score, which is determined based on SNP profiling across the whole genome, which will give us the copy number variation profile across the genome, and will give us the genome aberration score based on the reference models. So SNP profiling across the genome will give us copy number profile, which is compared as compared to the reference model, and aberration score is calculated. And that's how we get whether HRD is high or HRD is low.
And how much patients have you had a concordance data of, Dr. Suruchi?
So we have validated 200 clinical samples, where we have got the accuracy of 97%, which were done earlier by other methods. And with myriad my choice, we have done about 5 to 6 samples where we have got 100% accuracy. And we have also done with reference standards, where again we have got 100% accuracy.
No, but how did you achieve at the score of 40 or something else? I mean, how did you achieve when they had a 42 score, and how did you achieve at the score 40? Or whatever is the reference? You said 50, then you said came to 40. How did you
So
achieve that
yeah,
number?
I'll tell you, sir. So it is based on SNP profiling, for example. So if we talk about MPAI kit, which was being used earlier by us as well. So that kit is designed based on 27,000 SNPs covering the whole genome. Okay. So they are using a cutoff score of 50, because when they use those SNPs and they optimize the assay or validation assay based on their reference models and all, the optimization for the cutoff happened at 50, that above 50 it will be HRD high, and below 50 it will be HRD low. We have designed the assay using 46,000 SNPs across the genome. So the optimization that we have got is around 40. So it depends on how we validate our assay. It is not absolute. I mean, it's not, the score doesn't determine that whether, or the difference in the score cutoffs doesn't determine whether the HRD assay is comparable to Myriad or not. How that assay is optimized and how it is working, and basically how it is giving the score out, that will determine its accuracy, not the cutoff value that we get. It, whether it is 40 or 42, it doesn't make much difference, because it is how the assay has been developed. The
That is
technical.
that is very important. Yes, Dr. Vindhya, you have a point.
So, there is one more lab, one more Indian lab, which for which we have been sending NGS, and on the NGS they were reporting HRD. Is it possible?
Ma'am, HRD can only be determined by two methods. One is like based on genomic signatures, LOH, TAI, and LST, those scores when they are calculated, or SNP-based profiling using copy number profiles. So we need to check what basically they are doing. Are they using off-the-shelf available commercial kit, or they are having a laboratory developed? To my knowledge, I am not aware. If we can discuss it later on.
Off record over here. So Dr. Vindhya, what are the challenges as a medical oncologist? What would you ask your molecular pathologist, the scientist, the bioinformatics report? What are the challenges that you face in the report? Once you once you get an NGS report, what goes in through your mind?
So first I look for this red bar, whether there is any pathogenic.
Correct. And then you say, let's go somewhere else. Okay.
Which is actionable.
Okay.
The challenge comes when there is a VUS, especially because when we counsel the patient, we tell that right now there is no data that this is pathogenic, but later on when more information accumulates, it might turn pathogenic, it might not. But how do we update the patient if the VUS becomes pathogenic?
Does the lab send because our lab sends all the VUS, they send a note to us in 6 months time. Since we have an in-house lab, that's very easy for them to do. Every 6 months they'll say this was VUS, now it is still remains VUS, or this has been upgraded to a pathogenic variant or not. But does the other lab also do? Dr. Feroz, if you can answer that.
Dr. We also have a practice, sir. Like usually we tend to relook every 6 months, and if there is anything which comes out, then it is informed to the clinicians.
Okay. Okay. Dr. Vindhya, do you get this thing answer?
Yes.
Okay, you did get. Any other VUS is one thing which you find challenging. Any other challenge?
When there are co-mutations.
Correct.
Some rare, like there is ROS mutation, not a fusion.
Or an ALK mutation which is there. Sometimes you do get these challenges. And so how can, let's say Dr. Suruchi, how can we overcome these challenges that the oncologist faces?
Yes, sir. When we have co-mutations or we have uncommon atypical mutations, definitely the challenges that you face, we also face as molecular scientists, because the data that we report is based on the available literature evidence. So definitely we have to take it with a pinch of salt, and we have to do a little bit of more analysis, looking at, is there any literature evidence, or is there any case that has been found similarly with those mutations, or how those mutations were treated in past by some other clinician. And molecular tumor boards holds very much importance in such cases. When we do have multiple mutations or difficult to interpret mutations, we can have the opinion of different oncologists and molecular scientists on board in the molecular tumor board discussions.
That is the place where the molecular tumor board comes up. A typical way be to assign this report to a bioinformatician scientist, PhD at the molecular lab, give the same report to a clinician and tell them you come with the answer. Your fellow has to do the hard work, and then you come and sit in the tumor board and you pass a judgment upon what exactly to be done. But it's fun. It's actually fun to be over there. I have actually 2-3 cases which I can show you later. So I'll just tell you, we had a BRCA mutation in lung cancer. We did find out that 2.2% of BRCA mutations in adeno and squamous have BRCA mutation. Then we went back and read the literature. BRCA mutation in lung cancer does not have any increased platinum sensitivity. It does not really respond to PARP inhibitor, and there's evidence to show that. So initial 7-8 cases that we had, we gave them PARP inhibitor, did not respond. Then we have the literature because our resident did go and read that one. So now we are much more wiser. Even if we get a BRCA report, we do the due diligence, but we don't really act on that as well. We don't get very hyper on that. So that's the benefit that the molecular tumor board has actually shown to us. The NGS reporting, Dr. Feroz, is the NGS reporting format uniform across all the tumor types, or is it different for lung, colon, or is it similar across various labs also?
So actually, most of the labs will follow the guidelines. Like for example, if the lab is NABL or CAP accredited, then there are set guidelines which a report should minimum have. Like say for example, you have a any solid tumor report, be it lung, colon, or adenocarcinoma of breast, then you have to give the tumor size, tumor block number, or tumor content cellularity. These are the basic information which I think most of the labs will do.
So out of
And
100 labs that we have in over here, how many are following this structured variants? Keep a hand on your heart. We are ending. Dinner is ready.
we do, sir.
No, you do. Tell me, you when our own committee is everybody doing it? Okay, but I take your silence as an answer, which I will leave everybody to. But I think we should, as a clinician,
Yeah.
as a society, and especially I think AMPI should take a step in that, in kind of really standardizing the report. I mean, these educational webinars are okay, but we need to put them across onto the board. From my side, at least tumor cellularity, diagnosis, DNA, RNA, the AMP classifications, fusions, this thing, whether it is VUS, VAF, should be reported the way it was reported earlier. There is always a first time to report. There is no harm in starting it. Just because you haven't started it till now, we need to start it always. And that is how we will increase the uptake of NGS in amongst the medical oncologists also, actually. So let us go for here. Okay, Dr. Soruchi, I think this will go for you. We, I mean, a lot of time on WhatsApp tumor boards, we get this C797S. After osimertinib, people get an NGS and then C797S, either in trans or cis. So what is cis? What is trans?
So basically, when it is coming from a same clone, then it is cis. And how do we know? Through next generation sequencing, when we look at, so this is an IGV snapshot that I was talking about. So when we visualize this particular frame in integrative genomic viewer, because these mutations, they are adjacent. So they can be visualized in a single frame. And we can know that if it is coming onto the same read, in this picture, it is coming on different reads. So this is trans. But if T and C change had been coming on the same read, it would have been cis. So this gives us the information whether there are two clones, one having T790M and one having C797S, or there is a single clone having both the resistance mutation together. So depending on that, the choice of tyrosine kinase inhibitors, it differs in the resistance settings.
Absolutely right. Yes, Dr. Feroz has a point?
I think I agree with what Dr. Suruchi said.
Fantastic. Hematology, I am not covering in this thing. Okay, Dr. Vindhya, we will forget whether we are from MedGenome or Unipath or whatever, or Core or whatever. How do you select the laboratory? So I am at a very nice position. I don't have to select. We have an in-house lab. So we will do whatever my boss says. I will say, okay, we are doing this. How do you select?
One is
Somebody
the robustness.
who gives it cheap?
Their validation over the standard test.
Okay.
And yeah, of course, cost also plays a role, the turnaround time.
Okay. But have you ever asked for a raw data from them, Dr. Vindhya, and have they given it?
No, I haven't asked for a raw data.
You haven't asked for it. So if I ask Dr. Feroz for a raw data tomorrow, I mean,
Immediately,
how
24 hours.
24 hours you will give.
Because
Okay.
now, so now this is a routine thing now, and most of even the clinicians, they are looking for, especially in rare diseases, and everybody is asking for raw data. So that is now mandatory. You have to give the raw data.
You will give.
Okay.
And if I send a same, so what is the concordance rate now, since we are almost 1 or 2 minutes only we have, what is the concordance rate if I send a half sample to you and half to Dr. Suruchi and half I'll keep with me? 33. How much is the concordance report between all the labs?
I think 100% it should match,
100%.
unless and until there are no technical.
Firoz is absolutely politically correct today. Okay.
So tumor heterogeneity may play a role if you are dividing the tissue. I am being a devil's advocate here.
So I will tell you, no. So if you send a lung cancer patient to me or somebody else, there will be heterogeneity. You send it to Kumar, Kumar will treat it differently. I will treat it differently. There should be. Otherwise, medicine will be a science and not an art.
Yeah.
I honestly am a believer of art of medicine more than science of medicine. I do believe there will be heterogeneity. If it is less than 5% LOD, as you say, I'm absolutely okay with it. I think just last one, Dr. Suruchi, if you can tell me the AMP guidelines for this, and then we will just answer if there are any questions and go for dinner.
Yeah. So I think this slide probably is about like how do we interpret germline or somatic variants. So there are ACMG guidelines which are used for interpreting germline variants, where we classify them as pathogenic, likely pathogenic, or variant of uncertain significance, which are usually mentioned in the reports. But for somatic, when we do the test on tumor or on liquid biopsy sample, we classify them based on tier system, tier 1, 2, 3. 4 and 5. So basically tier 1 are the ones for which approved therapies are available in that particular indication, which is indicated there. But tier 2 will be when there is a approved therapy for that particular variant or gene, but it is not in the indicated tumor type. So in those cases, it is off-label. So that is tier 2. And tier 3, when we do not have any prognostic or therapeutic significance clearly mentioned in the literature, will be tier 3 classification. So this is the usual classification system which is used, I mean, in very short, for classifying the somatic variants.
Right, and this is what exactly I have seen actually, that people are now actually following these reports. Previously, 2, 3, 4 years back, I would have said a lot of people don't follow, but not, most of the service providers are now actually providing these reports. I think that was the last one that I had. With this, I will answer the question which was asked to me. See, let's say you have an EGFR mutation in a non-smoker at a VAF of, let's say, 4.8%. In a mildly symptomatic patient, let's say patient has a lung mass with only some bone mets and all, and the patient is okay to probably take some treatment, I would like to give them the benefit of EGFR mutant therapy. However, if the same patient has got a lot of liver disease, brain disease, I will not rather like to give, I would like to probably combine them with chemo and all. So a personalized medicine, you have to look at the molecular pathology, also look at the clinico-radiological position. So right now we had a patient who did not have any EGFR mutation to start with. We did a NGS panel. We gave him immuno plus chemo. On progression, we got a CGP done. At a CGP, EGFR L858R was 4.8%. So I said, he said maybe it was a more sensitive, there was more depth of the coverage. That is why we're getting it. I'm finishing my chemotherapy. Since I don't have anything else to give after that, I will give them oral TKIs at the end of it. So a lot of factors, including clinical, patient's age, the risk of progression goes into it. It's not really a clearly black and white answer for that. For the head and neck panel, unfortunately, you won't get much. You will get P53, you will get HRAS, NRAS. Rarely you will get some other fusions, but that is EGFR amplification is sometimes you get in head and neck cancers. Dr. Suruchi, there's a question for you. What is, this is what I've answered. What is GIM score, Dr. Suruchi?
If I'm understanding it correctly, is it related to HRD? Then it
I
is
think
a
it's
genome.
for the HRD, yes. That is asked at that time only.
Yeah, it's a genome aberration score, which we calculate based on the genomic signatures that we observe across the genome by SNP profiling or CNV profiling.
Okay. So I think this is already 1 hour, 30 minutes. And as Dr. Mishra said initially, 1.5 hours will pass and we still are, at least I am slightly more educated than I was before starting this. Any parting comments from any of the panelists? Otherwise, we will send it to hand it back to the organizers. Dr. Vindhya, Dr. Feroz, Dr. Suruchi.
Sir, there is one last report of fish. If you're able to decode it, that would be great, sir. Fish report is there.
Fish, I thought I will not discuss actually. I will just do that. I had actually, hidden that thing. I will just do that. Okay, let me just see. I thought fish doesn't come into molecular now anymore. Yeah. So I thought, is this the one? No.
No, doctor, this is
Okay,
about,
this is about that. Wait, let me just see if I have that.
it will be in the end.
No, I don't have that report here, unfortunately. Okay, let me see this one.
Yeah, this is.
Yes.
This one?
Yes, yes.
Okay, fantastic. So, Dr. Sorochi.
Sir,
No,
this is
it
to
is
Dr.
to
Minu,
Dr.
sir.
Minu. Yeah.
Okay, yes, Dr. Minu. Dr. Minu has just left, I guess. Okay.
We can leave it, sir. Then. Thank you.
Yes. Okay. Fantastic. Thank you. So with this, thank you, Dr. Feroz, thank you, Dr. Sorochi, thank you, Dr. Vindhya, for a fantastic discussion. I hand it back to the organizers.
Thank you, sir.
Thank you, Dr. Ulas.
Thank you, Dr. Ullas, for a very nice discussion with all the panelists. It is really a good discussion regarding the background jobs, like what happens in the lab and also what's come out. It will help both for the young pathologist, small pathologist, also for the clinicians. It's really very good summarizing discussion regarding what we should expect from a report, how to understand it. So
But
thank
I
you all the
think
panelists and also.
I think you should involve the medical oncologists more into this discussion. I mean, it is they who will benefit the most, sir. It is not the pathologists. It's the medical oncologist fellows who
Yeah.
should come and attending this, sir.
Ullas, as of
Sir,
now,
it's basically it's three stakeholders here. One is the pathologist. One is, you can say the many pathologists now converted to molecular pathologists. So it's a path, small path, and the clinicians. So
Yes.
this is you can say a triangle which is going across uh, uh, to give the best benefit to the patients, sir.
Correct.
So in the future discussion, will include more oncologists to the board, so that it will be more meaningful discussions. So as you have already highlighted, also Dr. Misra already highlighted, there are many labs now giving report. Most of the labs give the standardized report as per the AMP guidelines and ACMG guidelines for the germ lines and the CAP guidelines for the somatic, because almost many of the labs give, except a very few. And the rest regarding, I have only one comment regarding the split of the samples. So I think we should not split up the samples. You have to trust in a single lab wherever you are sending the standardized, whoever following the guidelines. So if you split the samples, it will be very difficult for even for the pathologist, even for the molecular pathologist.
Okay. Okay,
So
fine.
as Dr.
Okay.
Suruchi already
So,
told that the tumor heterogeneity.
okay, I will just like to say, sir,
Yes, sir.
it is just, I will never split a sample. It is just to, tell over there,
Right.
we just have concordance of that. So I will never ever split a sample. That's the first thing they told us to us in pathology. Like lymphoma, patient gets a biopsy done, send half year. Don't do that. I will never ever do that, sir.
So just clarifying a little bit, it will always different, because if you see the VAP will be different, depends upon the tumor content. So it will be difficult to interpret. Apart from the tumor heterogeneity, also even if the same tumor, if somebody has a more, somebody has a less, it might be difficult to get the VAP. So already many things have discussed, and I'm just we're already going almost 8:45 p.m. So thank you all, and it is the most integral part. Like whatever going in the lab, it should be get properly interpreted, and the things should be translated to the like the patient at the end of the day. So thank you. We should conclude this today's discussion, and now I hand over to the organizers. Now it is up to you.
Dr. Deepak, sir, any final words from your side, sir?
what it is amazing to see that till little while ago, 130 people were there when we finished. Right now, it is showing us 150. And 115 at 9 p.m. in the evening is a wonderful number. And I think what Ullas had said, that we must involve more and more medical oncologists and clinical oncologists in this particular program, so that they are also made as to how to interpret about even so it is very important. Wonderful program. Everybody has participated in a brilliant way. And I thank Ulhas, as usual, the master of such panel discussions.
Thank you,
I've
sir.
been listening to him numerous times, and he does a fantastic job. Moderate.
But last comment from my side, sir. It's as much learning for me than it's for every. I mean, I learned actually more after when I moderate. This was fun listening to both Dr. Feroz, Suruchi, Dr. Vindya, and I didn't really get much to talk to Dr. Minu, but fantastic. Thank you. Thank you for making me a part of this.
Thank you, sir. Thank you so much.
Thank you.
Thanks, everyone. Good night.
Thank you,
And
sir.
thanks for
everyone.
active
Have a-
Thanks,
participation.
everyone.
Thank
Bye.
you. Bye.
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 Thank you. Thank you. Thank you. Good night, everyone.